We are running short of time. I start the session. I welcome Dr. Lakshmi to talk about bone health and diabetes. Over to you, madam.
A very good afternoon, and thank you very much, DAISICON team, for having me here. And this is a very, very tall task to be talking about bone health in 10 minutes. But I will just give you the, as the title says, it's flashpoints in diabetes. So I'll just take you through what is very, very essential as far as bone health and diabetes is concerned. Now, all of us understand diabetes is a disease which has a lot of micro and macrovascular complications. But is there a diabetic-specific bone disease or diabetic osteopathy is what we are trying to extrapolate by thinking about bone and diabetes. So is there a direct effect of diabetes on the bone, by which I mean, do you have something with impaired bone health, bone fragility and fracture risk? So much so you can probably equate this with osteoporosis when it comes to people with diabetes who have a poor quality of bones. So osteoporosis per definition is a disease characterized by a low bone mass and microarchitectural deterioration of bone tissue, leading to enhanced bone fragility and a consequent risk of increased fractures. So that said, when you talk about osteoporosis and diabetes, you will definitely have to keep in mind that you are also dealing with type 1 and type 2. So in type 1, it is quite easy to understand that they probably have a poor bone mass all through because they've been having diabetes from quite a young onset. But when it comes to type 2, the whole idea is a little counterintuitive as to how you can talk about bone health in a type 2. So I will just come to it in a slide or two. So the magnitude of the problem, now this is a major as we speak. I think there are so many people who are right now fracturing their bones with fragility fractures, with just trivial falls. People just slip. All that needs for a postmenopausal diabetic woman to fracture is just a very trivial slip. And you will not even imagine that there could be a fracture, but they would have fractured a bone. So it is something like, it has a very, very innocuous presentation, but only if you x-ray that you actually see that there is a fracture. So there is a 2.5-fold higher increased risk of hip fractures in people with type 2 diabetes than the general population. Of course, age, duration of diabetes, HbA1c, the kind of drugs that we use typically today with the advent of SGLT2 inhibitors and the kind of weight loss medications that we have today, along with sarcopenia, we also have to keep in mind that there is a hit on the bone health that kind of parallels the kind of weight loss that these normal drugs actually bring in. So in a type 1 diabetic, the increased fracture risk is associated with the microvascular complications, HbA1c and the duration of diabetes. But when you look at a type 2, both high and low HbA1cs can push them into increased fracture risk. So it is not just a linear relationship with HbA1c, it can be on either sides of the spectrum. So in a type 2, proximal fractures are more due to osteoporotic risk factors, whereas distal fractures can be more due to the microvascular diseases per se, insulin use and other diabetes-related factors. So to understand what happens to bones in a diabetic, we will have to know a little bit about the characteristics of bones. So in a type 1, I think it is very easy for us to understand. This is how the peak bone mass is actually achieved. So you typically have this person getting the peak bone mass around 18 to 20 years of age, and then it kind of plateaus over a period of time and starts falling as age advances, and this is more sharper in women as they tread into menopause. So along with this, when diabetes is compounded, naturally there is a sharper fall in the bone mass which happens in people with type 2 diabetes. So in a type 1, when they have a problem at the peak age of bone accrual, it is quite understandable that they have weaker, thinner, smaller bones. But what happens in a type 2 is slightly paradoxical. So what is the paradox? You could have a normal or even an increased bone mineral density, but still these bones are technically weaker. Why do I say that? Because the increased fracture risk in these people is because of changes in the bone microarchitecture. Why that happens is that you have a lot of trabecular damage that happens in the bone and lot of porosity of the bones that happens in a type 2, and the bone turnover rate is also reduced. Because of this, you have a bone which is there, which is probably higher in BMD but poorer in the tensile strength and the microarchitectural strength. So if you compare the bone of a postmenopausal woman who has diabetes and who does not have diabetes, as you can see, the porosity is so much more in a diabetic postmenopausal woman compared to a non-diabetic counterpart. So that is the main point that we need to appreciate when it comes to understanding how qualitatively the bones are deficient in an individual with type 2 diabetes, all the more in women. That said, you will have to probably see, I've always been very, very impressed with the pathophysiology of what happens in diabetes and bone. So when you look at the mesenchymal stem cells, they actually have to differentiate into the osteoblast through the WNT pathway. And osteoblast, as you all know, deals with bone formation. And this is kind of, pumped up by the mineralization of the bone with vitamin D, calcium, parathormone, so on and so forth. And on the other hand, you also have bone resorption that takes place through osteoclasts. So this is something that keeps happening on and on and on. The bone is not a dead tissue. The bone is something which is very, very vibrant. As you climb on this podium, as I go down, even when you have a small strain on the patella or on the knee or on your ankle, the bone is constantly remodeling. So that is what is happening to the bone. It is not a dead structure where it is just there for you to just, keep it till the end of your life. You have constant work that happens in the bone. And in diabetes, this working is impaired. How is it impaired? When there is hyperglycemia, you don't have good differentiation of the MSCs to the osteoblasts. And plus, when hyperglycemia comes in, you also have inhibition of the maturation into osteoblasts. Vitamin D parathormone is also impaired and osteocalcin activity is also diminished. So all this kind of affects the bone remodeling cycle. Not only that, it also kind of shifts the differentiation of MSCs more towards adipocytes. So when that happens, you have increased production of adipocytes and that leads to a lot of ROS. When there is ROS, again the cycle repeats itself in the form of on and on, the MSC only keeps on coming into the adipocytes. So in other words, you have a bone which is more into the adipocyte differentiation than into the osteoblastic activity. So you have, in other words, obesity of the bone that happens in people with type 2 diabetes. So all these risk factors, age, gender, microvascular complications, and then your the drugs that you use, iatrogenic causes, all this can put your patients with type 2 diabetes at increased risk of fractures. So not only that, one part of it is that they are at risk of fractures. The other half is what happens when they fracture. When they fracture, the fracture healing is not up to the mark. For obvious reasons, the cartilage formation is not excellent. You already have problems with the bone mineralization that can happen in a type 2. Over and above that, you'll have to keep in mind that the MSC pool and the availability of osteoblasts is bad. Microvascular complications are there, you have issues with blood supply. So all this kind of gives in what is called an inferior callus when it comes to bone healing in a person with type 2 diabetes. So the problem does not stop just with the fracture, the problem also continues with respect to how this fracture can actually heal. Not only that, we all understand problems with delayed union, non-union, perioperative complications. People have a lot of cardiovascular issues when it comes to, it is not easy to operate a 70-year-old diabetic with a cardiovascular comorbidity for a fractured femur. See, there are so many things that happen between the, in the pre and post-operative period. So definitely the morbidity is much more. So what do we do to evaluate this? Naturally, you are interested in looking at the basic blood work, calcium, albumin, vitamin D, TSH, parathormone, electrophoresis in patients in whom you have suspicion of other causes for a poor bone health, spine X-ray, DEXA, bone scan, and bone biopsy. Now, BMD is by far the most sought after thing that you look for osteopenia or osteoporosis. So -1 is normal, -1 to 2.5 is osteopenia, and less than -2.5 is osteoporosis. So this is what it is. So people who are more tech savvy, you want something easier than just sending them to a scan center for a DEXA, you can always do the FRAC score. Now the FRAC score, all you have to do is just key in all these things and then it gives you the 10-year risk assessment for fracture. RA serves as the proxy for diabetes in this assessment engine. But nowadays you have the advanced FRAC score which also factors in diabetes. Other CT-based techniques, bone indentation techniques, trabecular bone score, and then your bone remodeling markers, all this I will skip for the want of time. But ultimately, indications for a BMD testing is definitely there for any elderly individual, regardless of clinical risk factors, or in people less than 50 years of age if they've already had a fracture in the past. Apart from that, if there is one thing that I would really like to recommend, I think getting a routine thoracolumbar X-ray in most of your patients, especially people above the age of 60 that come to your clinic, I think that gives you a lot of information. If there is a reduction in the height of the patient, historical height reduction of 4 centimeters or more, or a height reduction compared to what they were last year to what they are today. Because we generally do the height, weight, and BMI, but not many times we really think that the height can vary in your elderly patients with diabetes. So just a reduction in the height means that there could have been a vertebral compression fracture, and most of these are women who just go around with a vague back pain. They don't even know that they have fractured. So unless you actually do this, you will not be able to pick up all these things. Treatment is of course, calcium, vitamin D, and then strengthening of bones, take care of the diabetes, alendronate, bisphosphonates, raloxifene, calcitonin. I think teriparatide is hitting it very high today because almost every other patient who has a long bone fracture is invariably discharged on a teriparatide, if not by us, by the ortho colleagues. And of course, treatment of diabetes, you have to be very, very careful. Avoid drugs that can push them into fracture. Most importantly, TZDs in postmenopausal women, use it with caution. And all other drugs, the only major risk is that with hypoglycemia. You don't want your elderly people to have a hypoglycemic episode and have a fall. And like they say, it takes a lot of skill to trip over flat surfaces, right? So the main crux of the story in all this is to prevent a fall. The last two slides that I have is just to reiterate, because most of you are clinicians here. So I've always had this tilt towards clinical medicine. So when you hear hoofbeats, think of horses, not zebras. But sometimes it is important to find zebras among horses. Now this is a 85-year-old lady with a domestic fall with a fracture femur. But perioperatively, her bone strength was so poor and so fragile that we were tempted to send it for a biopsy because the bone quality was so poor, ended up being a carcinomatous deposit, and that was a secondary pathological fracture. Now this again was an elderly lady who came in with back pain with a compression fracture, also complained of cough for 1 month, and in fact she thought the back pain was because of the cough. Ultimately she had active TB with a pot spine. Now this is another 47-year-old postmenopausal lady, all Kaikal Kodachal syndrome. Look at the parathormone, 579, and she had an inferior parathyroid adenoma, which we were able to operate, and she had a good quality of life. So why I'm saying all this is diabetes and osteoporosis are very similar clinical entities in the sense both of them are prevalent, both of them are largely asymptomatic, they need aggressive screening, they produce complications if left untreated, and yet both are preventable. I think that is the most important thing. And diabetes impacts bone, and I think diabetic osteopathy is something that we have to consider similar to the lines of all the other microvascular complications of diabetes, because it is a silent epidemic today. And of course, both type 1 and type 2 can be affected by the so-called bone-related complication. And diabetic bone disease in a type 2 largely results from obesity of the bone and results in 3 Fs, which is fragility, falls, and fracture. Certain drugs for the treatment of diabetes may have to be avoided in people who have a poor bone health. No specific guidelines are there which are quite specific for diabetes. So till such time, the general guidelines for osteoporosis is what you have to follow when you treat people with osteoporosis and diabetes. I'll stop there. Thank you very much.
Thank you, madam, for the nice presentation. Audience, any question? Maybe we can take one question. Anybody? Okay, thank you, madam. If there are no questions, we go to the next speaker. I invite Dr. Namita Narayan for presenting the diabetes and women, madam. Over to you, madam.
Very good afternoon to one and all gathered here. At the outset, let me thank the DAISICON organizing committee, especially Dr. Shanmugam sir, for this opportunity and a challenging topic. One, to talk in 10 minutes about diabetes in women. Another challenge is to talk after Lakshmi, as always. So diabetes in women, I'll just, for this given 10 minutes, I'll try to do justice of what can be done. So I'll be taking you through the different phases of a woman, right from adolescent to an elderly, and what are the unique issues that she has: PCOS, pre-existing diabetes and pregnancy care, complications specific to women, breast cancer and sexual health. So diabetes behaves differently in men and women. Women face more pronounced fluctuations and physical challenges, mostly due to reproductive factors impacting their diabetes management. Type 1 diabetes, poor metabolic control in type 1 may lead to hypothalamic amenorrhea, whereas overweight, obesity, PCOS can lead to infertility in type 2 diabetes. So adolescent years, that is the most happening time, phase of significant change both physically and psychologically. Menarche, again, in type 1 diabetes, it is said that they have a late menarche and an early menopause. And menarche is a time when the glycemic management is going to be really, really tough. They have a high demand of insulin and highly unstable glycemic management. So we need to be on toes to treat those kids there. Weight gain and eating disorders happens, and they have their own, their body composition. They are very worried about it. And suboptimal care, most of the girls, though we say we are in to 2025, they are not taken care of properly, especially in peripheries, and we have a risk of decay. And all this put together, you have risk of depression and psychological changes happening in the child there, and all social issues and stigma. The parents are worried whether they can get her married or not. If she gets married, whether she can get pregnant or not. So all these are unique challenges. And again, the reproductive age group, very crucial phase in glycemic control again. As I said, type 2 diabetes, obesity, PCOS and infertility, which I'll be coming to in, later on. and pregnancy and its complications is a separate topic in itself, and most common infections, UTI, especially in women, genitourinary health. So in middle years, what happens? Perimenopausal, again, hormone fluctuations there, age where she gains weight, increase in waist circumference, and as Lakshmi already told, she has osteoporosis, osteoarthritis to add on, other autoimmune disorders, so all put together. And when compared to men, men are diagnosed with diabetes in a younger age with a lesser BMI. But when it comes to women, it is mostly in perimenopausal or postmenopausal, and they are obese, waist circumference is high, and they come with fully, full atherosclerotic events and more prone for cardiac complications. So death rate in a woman with diabetes is triple the time when compared to a woman without diabetes. And so what is the take home here? Need for screening all women at this age group, perimenopausal and menopausal, for diabetes. So that should be the take home for women with elderly. And now elderly, a very vulnerable age group. We have osteoporosis there, so, and also sarcopenia. We keep talking about exercise at least 300 minutes per week, but where do the women exercise? They say, ma'am, we don't have time. Morning they'll have to cook, afternoon they'll have to cook, they have to take care of the children, so they generally don't exercise when they are supposed to do and end up with sarcopenia in the older age group. Frailty, increased falls, and visual and hearing impairment. Though they take care of the family, they don't have people to take care of them, so I have seen patients who are not able to take their insulin dosage correct because of their visual impairment. So all this can happen. With all this in the background, now prevalence of PCOS in India, studies said that it is about 10.8% in India. And I'm not delving into the pathophysiology of PCOS. So symptoms of PCOS, as we all know, insulin resistance is the bottom line, be it a lean PCOS or an obese PCOS. So insulin resistance is the bottom line, leading on to infertility there. So what are the conventional antibiotic therapies we have in PCOS? We started with metformins. Now GLP-1 and SGLT2 inhibitors are playing a very major role there. So what happens is with GLP-1, we know that obesity comes down. So with obesity coming down, they have more chances of having decreased anovulatory cycles and getting pregnant during treatment. So as we all know, SGLT2 and GLP, both are not as such, as on date, are not recommended during pregnancy and lactation. So maybe we'll have to advise them that is a pre-conception counseling has to be given for them, not to get pregnant while on treatment. And there are studies which have shown that starting GLP-1 24 months, that is 2 years prior to planning pregnancy, has got a good perinatal outcome. So why do we need to care for women during preconception, say a type 1 diabetic getting pregnant? So we all know the long-term fetal risks and the maternal outcomes. Maternal outcomes, they are more prone for, say she's diagnosed with GDM or she's a diabetic getting pregnant. The cardiovascular events are more, the stroke incidence is more, and also they get into overweight and obesity. Whereas in fetal, outcomes would be, again, the child can have, when he grows up, or when he or she grows up, can have type 2 diabetes, hypertension, and other cardiovascular diseases, and also stroke. Diabetic lady getting pregnant, what will be the fetal outcomes? Stillbirth and other perinatal complications can also happen. So pre-conception care is very important, especially folic acid, take control of the body weight, blood glucose control is very important. So we say the fasting should be around 90 and random should be around 100, 110. We don't go beyond that. HbA1c of 6.5 pre-conception is what is mandatory. And anybody having HbA1c of more than 10, control the glycemia first and then go back for pregnancy. That is what is advised there. And it is also said that they are more prone for, or it is their retinopathy and nephropathy are unmasked during pregnancy, especially in a type 1 diabetic. So look into all that and then go ahead with planning of pregnancy. So GDM, I'm not delving into the topic for want of time. And moving on to complications unique to women. When compared to men, cardiovascular complications are more in women, especially heart failure with preserved ejection fraction. Though we have many trials, I think the Emperor trial, we saw that SGLT2 and SGLT2 inhibitors would be helpful in heart failure with preserved ejection fraction. And again, why it is more is, we all know that estrogen is protective, but what happens in diabetes is, diabetes more severely reduces the endothelial responsiveness in females than in males. So what happens is, changes the advantageous hemodynamic effects of estrogen through intricate interactions between insulin and estrogen signaling, thereby putting women at higher risk. So the anti-inflammatory or the anti-proliferative effect of estrogen is gone in a patient who's got a higher glycemic control. It's not moving. Slide is not moving. So yet another complication which is more when compared to men is psychosomatic stress and depression. Though depression is seen in both males and females, it is seen more in males. And another complication, as we all know, genitourinary infections. UTI is more common in females than compared to males. So as I said, women suffer twice when compared to men. And again, hormonal changes may be the cause, and genitourinary infections also have dealt with. And what happens is, genitourinary autonomic neuropathy causes dysfunctional voiding and urine retention, which reduces physical bacterial elimination by micturition and promotes bacterial growth. So this is one thing. And as we all know, diabetes also causes increased risk for malignancies, especially breast cancer. Why? Because there is an increase in IGF-1 factors, which is, again, as we all know, the ratio of IGF-1 to IGF-BP3 is critical in determining the breast cancer risk. So I'll take 1 more minute, sir. Again, inflammatory cytokines, especially interleukin-6 secreted by tumors linked to diabetes, promote insulin resistance and cancer progression. And type 2 diabetes also increases the risk of chemotherapy-related toxicity and worsens outcomes in breast cancer patients. So menopausal hormonal changes, all of us know, that is the time when a woman gets to be diagnosed with diabetes. And again, what happens there is increase in insulin resistance, altered fat distribution, fluctuating blood glucose levels, all are causes, and you have increased risk of cardiovascular complications. Hormonal replacement therapy in women with menopause, it has to be on a personalized basis, one-to-one. We'll have to sit and talk with the patient and take up, because hormonal therapy will definitely decrease the incidence of, or it will prolong the incidence of diabetes, but it may not be helpful every time, but as it also increases the risk of breast cancer. Diabetes and risk of osteoporosis has already been dealt with. One thing which I wanted to tell you here was reproductive and sexual health of women, which the woman also doesn't come and tell us, and we also don't ask her about it. She has so many female sexual dysfunction is encountered, especially in people with diabetes. That is because of the vascular damage and neuropathy brought on by diabetes, which frequently result in decreased sexual desire, painful intercourse, and problems with arousal, which also causes psychosomatic stress and maternal discordance. So causes being all these: genetic predisposition, endocrine disorders, vascular complication, lifestyle factors, neurological factors, and mental health, not to forget about the chronic inflammation. So to put it in a nutshell, what happens in males and females is, as I said, the diagnosis in males is at a younger age and a lower BMI, whereas in females it is at a higher age with all complications, especially hypertension and obesity. And there is an impaired glucose tolerance in the perimenopausal years, whereas it is an increased fasting glucose, which we see in men. And not to forget about the sexual hormones, a decrease in testosterone is actually beneficial. An increase in testosterone and a decreased estrogen in males and a decreased testosterone in females, and prior GDM. All this will complicate diabetes in females. And the complications, again, psychosocial factors, increased diabetes distress, increased psychosocial stress is also seen there. And what happens to the complications here? There is a relative risk or increase in heart failure and cardiovascular mortality in females more than males, and also the same with increased relative risk in renal insufficiency and failure in females more than males, whereas incidence and progression of diabetic retinopathy is one and the same in both males and females. Whereas males have an increased diabetic foot and increased amputations, females, they have increased neuropathic pain intensity, and increased nerve injury, all leading on to depression and anxiety. Moving on to the treatment, again, there is more of under-treatment, and most of the trials, I think women are not represented much. And basal insulin, again, in males there is a decrease in HbA1c on target, whereas in females, GLP-1 agonist does work well, but the complications again are more in females. Sulfonylureas, it is both same in males and females. SGLT2 inhibitors, again, the UTI risk is supposed to be increased more in females. I think with this, I'll end my talk. Thank you once again for this wonderful opportunity.
Thank you, madam, for covering all the areas of diabetes and women. Any questions from the audience? Thank you, madam. Next, I call upon Dr. N. Kannan for discussing diabetic cardiomyopathy. What clinicians should know? Over to you, sir.
Thank you for the opportunity given to me. Friends, this topic, why it is important? Because this topic we usually miss in our clinical practice while we seeing a patient. Because we most fond of seeing these three categories: pumps, pipes, and filters. We know how to treat the complication regarding with the filters, and also we know how to complication regarding with the pumps. But of late, pipes, and of late, we are not focusing our patients on the prevention of the pumps complication like diabetic cardiomyopathy, and also diabetic cardiomyopathy progression for the diastolic dysfunction or systolic dysfunction. Braunwald endorsed this important this one wording regarding frequent, forgotten, and fatal. See, in our clinical practice, even with the availability of simple investigation, exercises, PAV, echocardiogram, we are not doing any tests regarding with the cardiac failure manifestations. So we usually forgot, and usually it's frequent among the patient and fatal, that already we learned about from the Trivandrum heart failure registry, almost 60% of the type 2 diabetic population are suffering from either in the form of preserved ejection fraction failure or reserved ejection fraction failure. See, in definition, diabetic cardiomyopathy is defined as a myocardial dysfunction that is very important, maybe structural or functional, occurring in diabetic patients independent of the ischemic involvement, and also independent of any vascular involvement, and also no hypertension. So these are the important categories that we want to realize before labeling a patient that they have diabetic cardiomyopathy, either in the form of reduced ejection fraction or preserved ejection fraction. It's integrated with other problems also, including the kidney and vasculature, including both microvascular as well as macrovasculature. Etiology and epidemiology is also very predominant. Almost 60 to 70% of the diabetic population over the period of 10 years, they will have either in the form of preserved ejection fraction impact or reduced ejection fraction impact, going for decompensation of cardiovascular diseases. So duration of disease, duration of diabetes, when we want to implicate the diagnosis for this patient, because any patient has the history of diabetes more than 5 years, any patient has the history of diabetes more than 10 years, they have been evaluated for the presence of this important manifestation to prevent the complication. One of the worst complication, not only for the patient, also patient quality of life, and also patient attendance also will be suffering like anything. So the poor glycemic control is one of the main menace, and the burden of DCM is expected more and more in upcoming days, because we have high ICM in-type data, we have more than 100 million population suffering from diabetes. So with the emergence of high prevalence of diabetes, the emergence of DCM also will be more. This is data from UKPD 69, increase in 1% with HbA, there is increase in the heart failure by 8%. This is the interesting data given by our own South Indian peoples. So they find out among the risk population even by hypertension and diabetes, smoking, and so on and so forth, but diabetes only is an independent risk factor for the prevalence of this one, reduced ejection fraction failure by more than 50%. But if you see the survival benefit, see the risk rate by 10 years, almost 70% of the population are able to have the high mortality with the diabetes and also heart failure. Deadly quarter pathophysiology involving metabolic stress due to hypotoxicity and glucotoxicity, and also going for oxidative stress inflammation, including the tissue necrosis, this one, the TNF alpha activation, RAGE activation, and also this one, oxygen species activation, going for more and more oxidative stress inflammation, and also microvascular dysfunction, fibrosis. Fibrosis is a growth factor, beta also have been involved in the more and more beta, this one, apoptosis of the cardiomyocytes as well as the fibrosis of the cardiomyocytes. Once again, glucotoxicity, lipotoxicity, going for this switch, metabolic switch, because see, the myocardium is more dependent on the glucose oxidation, because they play the important role on more ATP. ATP have the myocardium, glucose ATP will have high fuel. high power other than the fatty oxide ATP. So there is metabolic switch. In glucose ATP, this fatty oxidation have been playing into role, and therefore there will be more and more reactive oxygen species over the cardiomyocytes, and also there is more and more with the oxidative stress on the endoplasmic reticular stress and going for altered myocardial energetics and bioenergetics. So increase the lipid accumulation, because there is more and more accumulation of the TGL due to increased lipid oxidation. This furtherly going for the progression of stage 1 to, this is normal to diastolic dysfunction, decreased ejection fraction failure, and reduced ejection fraction failure, systolic, systolic failure, as well as the end stage cardiac failure or decompensated cardiac disease, and so on and so forth. See, clinical features, very, very simple. Whenever you see a patient, just identify by the look itself whether they have any breathlessness. So that is subclinical stage. Any patient having the breathlessness, we want to set the patient, we want to fix the mind that the patient having some sort of cardiovascular problems is undergoing. So there is early DCM in the form of diastolic dysfunction with preserved ejection fraction, and also there is advanced DCM in the form of reduced ejection fraction. Is very, very fulminant, and the mortality is more than 70% with reduced ejection fraction failure with the patient going for EF less than 40 or less than 30. Diagnostic tools. Dear friends, X-ray chest PA view. With the seeing one single X-ray, we can easily diagnose by 20%. Basal congestion, predominant widened heart, was clearly eliminated, and also echocardiogram also played important. Now we are doing a lot of biomarkers regarding with brain activating peptide, NTBM, PRO-PNP, and we have gold standard, this one cardiac MRI also. But you have to rule out, this should be without hypertension, without any valvular disease, without any significant ischemic heart disease. What are the reflex for the clinicians? When the clinicians should suggest these patients have to be labeled for this ejection fraction failure, because the clinical scenario, I already told about whenever see the patient on the look itself, inspection itself to diagnose they have any preserved ejection fraction failure, and parallel microalbuminuria. Microalbuminuria is one of the earliest manifestations of both type 1 and type 2 diabetic patients. Any microalbuminuria patients should be subjected for evaluating for the heart failure, early diastolic change, that is, there is difference between the ventricular filling and also the ventricular ejection. So this should be altered according to the echocardiogram. So echocardiogram plays an important role to rule out the patient regarding with both in the form of preserved and reduced, and also any patient underlying retinopathy, neuropathy also, they have high chance of having the heart failure. Management, 4 pillars, lovely 4 pillars we have. Yes, or ARB, RAS, serotonin activation, angiotensin 2 activation we have. Beta blockers, negative inotropic effect, negative chronotropic effect by modern beta blockers like bisoprolol, lebivolol, carbidopa. MRA, we have phenylalanine, old ghost and spironolactone. We have multiple trials. RNA, nephrolysin beta, we have a paradigm HF trial. 26% reduction we are able to see with paradigm HF, and of late we are in the era of SGLT era. This molecule came for the glycemic control, but this is the molecule have been offered up by the multiple specialty, and now this makes the whole changing landscape of making the diabetic patient from the glucocentric approach to the cardiorenal approach, both empagliflozin and dapagliflozin. Braunwald entitled this medication as the gold standard, and these statins of the modern century. We have multiple data. Emperor data, DAPA data we have, emperor preserved, emperor reduced, and so on and so forth. Leader trial with liraglutide. Once a sustained B we have with dulaglutide, and so on and so forth. So there are multiple trials, landmark premium trials have been involved in multiple drugs. This one stage, this one pillars 4 and pillar 5 now we have. With these 4 pillars, we can easily treat in our clinical patient, especially with the diastolic dysfunction, not the systolic dysfunction. This paper article was presented by our own R.S. Lakshmi. Very, very important paper, my dear friend. This paper alludes the importance of benefits of SGLT betas in the usage of this cardiac failure. You may think this molecule came only for the diabetic control, but how this molecule behaves a good thing for the heart failure management. So this is the article you can enjoy like anything, because there is up signaling in the deprivation of the nutrient and the down signaling in the nutrition surplus. And this makes the cardiomyocyte housekeeper. See, the word is housekeeper, and thereby it plays an important role in cellular autophagy, endoplasmic reticulum stress, and also myocardial bioenergetics. Lifestyle, exercise training, simple exercise, Salt restriction is very, very important. Fluid restriction also plays an important role. Risk factor management. Whatever may be the advances in therapeutics, whatever may be advances in technology, but clinical medicine is very, very important. Examination. Clinical prayers, examine the thing properly, early intervention, optimize the therapy, look for red flags and maintain the thing. When we have to deposit the cardiologist, these are the things, heart failure symptoms, any abnormal imaging or poor response to treatment. So, they are my key takeaways. Diabetic retinopathy represents a distinct pathophysiology entity with significant clinical implications. Early recognition and intervention are essential for improving outcomes. The management approach should be multifaceted, optimal glycemic control. We have multiple drugs including SGLT, DAPA, along with liraglutide. Conventional heart failure therapies including beta blockers, phenylalanine, and also good diuretics and comprehensive lifestyle modification. Remember, DCM begins long before symptoms appear, so proactive screening in high-risk patients is justified. Thank you very much for the opportunity.
Thank you, sir, for covering completely. Any questions from the audience?
See, madam, if you see the prevalence of the diabetic cardiomyopathy among the young population, the main predisposing pathognomic factor belongs to genetic factor, that is diabetic cardiomyopathy or hypertrophic cardiomyopathy. But any subject we have already we have mentioned about the insulin resistance, or any patient with the family history, any patient with the central adiposity, adiposopathy, obesity, so hypertension individuals, those who have high risk stress factor, those who have high sympathetic drive. So these are the areas we want to consider, because sympathetic nerve trafficking is important both in kidneys as well as the heart, because that is increases the inotropes and chronotropes, contraction and contraction and this one, reducing both the heart rate. This increases the heart rate, going for more and more heart failure prevalence. So these are the basic things that we want to keep in mind. So these are the main areas we want to consider for the younger subject to form the diagnosis.
Madam, to add some points, like Dr. Kannan sir told, usually we do the screening only 3 things: ECG, X-ray, echo. This is routinely we do. Other things are needed only if necessary. For example, pro-BNP is very expensive. Once we suspect cardiac failure, because it is 1,500 rupees, we cannot do for everybody, we do only if necessary. Like sir told, elevated JVP, pedal edema, crackles, patient is having orthopnea, PND, then definitely patient will require admission, you have to refer to cardiology and go for other investigations. That is postpartum cardiomyopathy. That is different, madam. Yes.
So with this 10 minutes flash pass, I can justify this. Thank you, Kannan. Thank you for the chat.
Thank you, sir. Thank you for the wonderful presentation. Thank you, sir. I welcome the next speaker, Dr. Joseph Paneerselvam, to talk about snoring and sugar, a bi-directional relationship. Over to you, sir.
Very good evening, one and all. At the outset, I would like to thank the organizers of DAISICON for the opportunity. So my topic is about snoring and sugar. We all know the snoring is very important thing observed in patients with diabetes. With the increasing incidence of obesity and other metabolic disorders, so this incidence has become very, nowadays is an increase. So the presence of snoring increases the chance of diabetes and vice versa. So this is a very common phenomenon observed in diabetic patients. So diabetes and high sugar intake can contribute to snoring. So the patient may not be a diabetic, even in pre-diabetic and other individuals, the high sugar intake can increase the chances of snoring. So diabetes and obstructive sleep apnea, a common association with the increased prevalence of metabolic disorders. So significant bidirectional link exists between snoring and diabetes. So the presence of one predisposes to the other condition. So it is associated with increased morbidity and mortality. So that's why we have to know about this association, and so we have to find ways to tackle it. This is a snoring diagram. So for a free airflow, so this structures, the function of this structure should be intact: soft palate and the base of the tongue, uvula and tonsils. Whenever there is any pathology in this, any of the structures, it can produce snoring. The uvula vibrates during inhalation and creating the snore. It's very common in, so especially after the deposition of fat around the neck and the oral cavity and tongue. So the snoring has become very common. And what's the connection between this snoring and sugar? So snoring is very common symptoms. One of the common symptoms of obstructive sleep apnea, especially in obese persons. Even without obesity, the diabetes predisposes to the OSA. And OSA is linked to insulin resistance and type 2 DM. so because it initiates various inflammatory processes, thereby to increase the chances of insulin resistance and development of type 2 DM. So high sugar intake can contribute to weight gain, inflammation and insulin resistance. And this is the bidirectional, you can see the bidirectional relationship among the obstructive sleep apnea, obesity, metabolic syndrome and diabetes. So the diabetes and OSA, it has got bidirectional relationship. OSA and obesity and metabolic syndrome, they have got bidirectional relationship. The presence of one predisposes to others, ultimately they lead on to organ damage. So the pathophysiological processes that takes place due to this bidirectional relationship are increase in insulin resistance and hormonal dysfunction. So more release of stress hormones and inflammatory process will be activated, and ultimately it lead on to increased CV risk. And how might snoring contribute to diabetes? So there will be interruption in the oxygen supply to the brain because of as we all know, there will be disruption in the sleep cycle because patient will have frequent apnea and hypopnea episodes. Because of that, patient will have fragmented sleep. So it causes intermittent hypoxia, and it releases the stress hormones, especially the corticosteroids and other hormones levels will be increased, and insulin resistance and ultimately impaired glucose metabolism. So the way these processes can contribute to diabetes development. And you can see in this picture the bidirectional relationship. One end we have obesity and type 2 diabetes, the other end we have sleep apnea. There will be two different mechanisms. One is weight dependent, another one is physiology dependent. In case of weight dependent mechanism, there will be increased fat mass and leptin resistance, insulin resistance and hyperglycemia in one end. So it increases the chance of mechanical load and narrowing of the airway takes place, and ultimately it can predispose to sleep apnea. Now another mechanism is physiology dependent, especially when the increase in leptin and insulin resistance. So it increases sympathetic activity and decreased chemosensitivity takes place, thereby it predisposes to sleep apnea. In patients with sleep apnea, there will be intermittent hypoxia and sleep fragmentation, and again it activates sympathetic nervous system, oxidative stress increases, and inflammation and lipolysis takes place. Thereby it is bidirectional, so one thing predisposed to other. And how the snoring affects sugar metabolism. So mainly by these two mechanisms, sleep fragmentation, because of the frequent arousal. Patient will have frequent arousal during night hours, it will disturb the patient's sleep. And intermittent hypoxia can disturb glucose regulation. So it induces insulin resistance, and glucose intolerance can develop due to chronic deprivation. So they will have poor quality of sleep, and thereby the daytime somnolence will be there. It affects the patient's quality of life. So the OSA can worsen diabetes control and increase the risk of complications, and these patients will be depressed. So the depression also is commonly associated in patients with the snoring, which adversely affects the glycemic control. So what are the mechanisms by which the sugar contributes to the snoring? So there will be intense inflammation, the inflammatory pathways will be activated. So there will be restriction of the airflow and ultimately lead on to snoring, and it promotes weight gain and it increases the risk of OSA. So the weight gain will be there, and there will be deposition of the fats over the airways as well as over the neck and under surface of the tongue. So excess fat deposition can take place, increase the mucus production and fluid retention. Again, they can impair the airway, and it predisposes to snoring, and it affects quality of sleep also. So again, so this sugar, high intake of sugar, so it can lead to weight gain and obesity and increase the chances of OSA, and it promotes inflammation and oxidative stress. These are the two important things that can happen in patients with the high sugar intake and predisposes to OSA. So these factors can contribute to the development of OSA and severity. So what's the link between diabetes and OSA? The loud snoring. So even without obesity, the patient has diabetes, so the loud snoring is very common, and it negatively impacts glucose metabolism. So the catabolism will be activated, thereby it increases insulin resistance, making diabetes difficult to control. So the high blood sugar levels contribute to poor sleep quality and can worsen snoring. So intermittent hypoxia because of the fragmentation of the sleep, especially during night hours takes place. Again, it will increase the insulin resistance and higher blood glucose levels. And this is the another bidirectional relationship. What are the things that can take place? One end we have obstructive sleep apnea, other end we have diabetes mellitus. So the obstructive sleep apnea, it increases the sleep disturbances, thereby it causes intermittent hypoxia and daytime. So there will be decrease in daytime physical activity. So there will be activation of the pro-inflammatory pathways, and sympathetic overactivity also increased, and increased oxidative stress. So in the other end we have diabetes mellitus. So there will be increase in counter-regulatory hormones, there will be increase in cortisol levels, and decreased adiponectin, and increased ghrelin. This is a hormone, it induces appetite, and there will be increased leptin resistance. This is a satiety hormone. So the resistance to leptin is very common in patients with diabetes. So ultimately they cause weight gain, and it predisposes to obstructive sleep apnea. So already we discussed the sleep fragmentation, insulin resistance, and the inflammation. These are the mechanisms by which the snoring and diabetes are linked. You can see the vicious cycle. So snoring and OSA can worsen insulin resistance and glucose metabolism. On the other hand, poor glucose control increases the chances of snoring and OSA. So that's why we have to control the weight. If really the patient is obese, it will improve the glycemic control, as well as even we can achieve remission by controlling the body weight. So breaking the cycle requires addressing both snoring and sugar intake. This is the vicious cycle. So the OSA, it causes upper airway changes, dysregulation of autonomic nervous system, and obesity, and it predisposes to type 2 DM, and which in turn causes increase in insulin resistance, inflammation, and the disruption of the glucose metabolism. So how to break this cycle, OSA and diabetes? So the two things are very common. We have to start with lifestyle modification. So like weight loss, healthy diet, regular exercise, and stress management. Another thing is patient should have quality sleep during night hours. And treatment options available are, especially for OSA, the CPAP is very successful. So the patient can have it in the house itself. So it will improve the quality of the life of the patients with the obstructive sleep apnea. And medications for diabetes management. So nowadays we have medications with the weight loss properties, such as SGLT2 inhibitors and this DP4 inhibitors we can use. And recently semaglutide and the tirzepatide, so they cause significant weight loss, thereby there will be improvement of the OSA. And recently in patients with morbidly obese persons, we can consider metabolic surgery. So even metabolic surgery can cause remission of type 2 diabetes. To conclude, so the relationship between the snoring and sugar is a complex and bidirectional. The presence of one predisposes to others, and it will cause organ damage. Understanding this relationship is very important for the patient management. So addressing both the factors is crucial for improvement for overall health and reducing the risk of morbidity and mortality. So thank you.
Thank you, sir, for covering entirely the OSA and diabetes. Any questions from the audience? Okay, sir. Thank you, sir.
Thank you, sir.
Then I invite the last speaker, Dr. Neochas Tharsis, to talk about lipoprotein A. Over to you, sir.
So good evening, everybody. So thanks for having in this program. At the outset, I would like to thank Dr. Shanmugam for giving this wonderful opportunity, respected senior doctors and chairperson. So the topic that has been tasked to me is lipoprotein A. So my session is composed of how lipoprotein A is relevant in our clinical practice. Right. Then what is the association between the lipoprotein and risk of coronary artery disease, and what is the functional properties of lipoprotein A and the indications, and what is the normal lipoprotein A level and the treatment. So South Asian individuals, they are representing almost 25% of global population, experience disproportionate high cardiovascular burden. So this burden has been attributed to many traditional factors like diabetes, hypertension, adiposity, lack of exercise and stress and so on. But what you have to remember that there are some underappreciated risk factors, for example, air pollution and some genetic factors and lipoprotein A. So if you look at the incidence of cardiovascular events in South Asian and Western population, just I want to give some kind of hints. How South Asians are really different from Western descent. First most important is the incidence of cardiovascular events 10 years earlier than the Western counterpart. And second one, the involvement of coronary vessels always multiple as compared to single in the Western population. And it is a non-calcified plaque, diffuse in origin. If it is calcified plaque, the chances of rupture would be less. When you have non-calcified plaque, the rupture would be more. This is the way our South Indians really differ from the Western. And there are many studies, including Caban-Hogan City Heart Study and Fourier study and the Interheart study, clearly demonstrated that there is very good linear relationship between increased lipoprotein level and coronary artery disease. Now, it has been clearly established that lipoprotein A is an definitive established risk factor for atherosclerosis and coronary artery disease and stroke and vascular thrombosis. Then apart from that, what you have to remember that this lipoprotein A is an pro-inflammatory molecule and it is always promotes vascular thrombosis. So, how lipoprotein A behaves? What you have to remember that lipoprotein A is almost identical to LDL. But how it differs from LDL? Just I want you to recall the structure of lipoprotein. You are all aware that all the lipoproteins like HDL or LDL or VLDL are composed of one core part, then the core is surrounded by one outer membrane. The core is composed of cholesterol ester and triglyceride. In the outer membrane, you must have one apoprotein, you must have one free cholesterol, and you must have phospholipids. That's very, very important. But in the most important, the peculiar feature of lipoprotein A is the presence of apoprotein A. The presence of apoprotein A, that is responsible for all kind of pro-inflammatory, all kind of vascular and thrombotic events. How apoprotein A behaves? Basically, apoprotein A mimics plasminogen. So what happens? It interferes with plasminogen attachment over the receptor, resulting in thrombosis, because plasminogen always promotes fibrinolysis, almost thrombolysis. So it interferes with plasminogen because of homologous identity. Likewise, it mimics like plasminogen activator and it interferes with the attachment, resulting in thrombosis. It promotes plasminogen activator inhibitor, resulting in thrombosis. Because of all mechanism, the one important thing is getting achieved. That's called, it promotes thrombosis, one. And second most important is, this is oxidized phospholipids. As I told you earlier, the outer membrane, there must be one apoprotein. Here the apoprotein A is present, that is more notorious. Then each and every lipoprotein contains HDL, everything contains phospholipids, but here that's something called oxidized phospholipids. This oxidized phospholipids promotes atherosclerosis. In many of the studies clearly reveal that during the, even while they are in the circulation, even LDL transfers many oxidized phospholipids to lipoprotein, which results in more and more atherogenic lipoprotein molecules are produced. Now it has been found that as compared to LDL, lipoprotein A is 6 times atherogenic. That's very, very important. Apart from that, apoprotein A promotes calcium and cholesterol deposition in the vessel interstitium resulting in aortic valve stenosis. So it is not only coronary artery disease, not only the stroke, not only atherosclerosis, it can induce valvular aortic stenosis. So what are the indications for screening? So basically it has been clearly stressed that lipoprotein A should be tested at least once in a year. So that is a new rule now. Because considering our South Asian ethnicity, it is always better to do lipoprotein A at least once. But there are very few strong indications where lipoprotein A must be done. One, when you have recurrent cardiovascular event despite on maximal statin therapy. One, when you have cardiovascular events but you are not able to identify any risk factors, do lipoprotein A. And when you have family history of premature cardiovascular disease, do lipoprotein A. Or when you have personal history of premature cardiovascular disease, do lipoprotein A. Then apart from that, when you have something called homozygous or heterozygous hypercholesteremia. Some patient, because of genetically determined this homozygous, heterozygous hypercholesteremia, they will present with LDL 500, 600 with all kind of xanthomas, then do lipoprotein A. Then when you assess atherosclerotic cardiovascular risk, when it is more than 10%, do this lipoprotein A. But most of the occasions, what Lipid Association of India and the Canadian guidelines clearly suggest that lipoprotein A should be tested at least once in your lifetime. So what is the level of lipoprotein A? Peculiarly, the adult serum level of lipoprotein A is attained at the age of 5 years. So 5 years kid has the same adult value. After that, so no diet, and no physical activity can influence your lipoprotein A. That's very, very important. Lipoprotein A level can't be influenced by your physical activity or diet. It is absolutely determined by your genetic parameters. And you have many isoforms. This apoprotein A, they are telling smaller isoforms will produce larger concentration. So that's a little bit theoretical part, I think that. So what is the normal lipoprotein A level? So if anything less than 14, then you consider that person is very normal. 14 to 30, he is under mild risk. 30 to 50, definitely moderate risk. Then if somebody has more than 50, that patient should be the target for treatment. So what is the treatment? Very unfortunately, the standard therapy, which is lowering dyslipidemia, doesn't work out for lipoprotein. So we don't have very good treatment for lipoprotein A at present, but there are two important molecules that are promising. For example, one is nicotinic acid. So nicotinic acid previously we used to give for high triglyceride. Because of this complication, skin flush and even precipitation of diabetes, sometimes elevated uric acid level, because of that it has been discontinued in between. But the problem is, even though niacin can reduce your lipoprotein level by 30%, you are not able to get proportionate positive cardiovascular outcome. So number wise it is able to bring down, but we are not able to get any kind of positive outcome. Then what about statin? Statin we have mixed result, but most of the meta-analysis of all kind of large randomized study clearly states that statins are not capable of bringing down lipoprotein A as expected. Then another one is the PCSK molecule, this promising. So it is able to bring down your lipoprotein somewhere around 30%, but only one thing is, because PCSK generally increases your activity of LDL receptor. That is the one that is very helpful for more LDL cholesterol. Even lipoprotein also being taken by same LDL receptor present on the liver. That's why it works. But only one thing is, the biggest problem is the injection. Apart from this, the cost. It should be given 140 milligram 2 weeks once. The one injection I think that the cost would be somewhere around 30,000. Then you have something called lipid apheresis. I have not exposed so far. It is something like dialysis where the patients, all kind of serum with rich amount of lipoproteins will be sent to the machine. The machine filters that extra lipids, then it will be sent, their serum will be sent back to the machine. Then you have the very promising one is antisense therapy. It is an engineered DNA molecule which targets the mRNA by which the production of apoprotein A, especially lipoprotein A, is reduced. But only one thing is, it is under phase 3 trial. Now they are able to say that it is able to bring down somewhere around 80% of your lipoprotein A from the baseline value. But please remember that lifestyle modification have very limited role. So one case study. So 40 years old male patient underwent mast-cell checkup. Her blood pressure is very normal. Family history of premature cardiovascular disease. BMI normal. Waist circumference normal. Waist hip ratio is normal. Glucose levels are normal. If you look at the lipid profile, everything seems to be little bit satisfactory. Is there any indication of statin in this patient? What is the indication? Sorry. Is there any indication for screening in this patient? Yeah, so family history is there. So because of family history, we are supposed to do. So the take-home message, lipoprotein A should be tested at least once in the lifetime, considering our South Asian ethnicity. Lipoprotein A level can't be influenced by diet or physical activity. To much our dismay, statins are not capable of reducing our lipoprotein A. Thank you.
Thank you, sir, for the wonderful presentation. Any questions from the audience? Actually, lipoprotein A was once upon a time we did all the tests during testing, but we could not understand what is lipoprotein A. Now we are able to understand better, and it's one of the emerging risk factor which can be tested. Even the ESC guidelines which has come up recently last week says it's closely associated with the atherosclerosis of the aortic valvular disease. And ApoB and lipoprotein A is a mandatory along with the lipid profile. That is what he highlighted. Thanks for the...
Actually, they have stated that evolocumab is capable of reducing by 30%, but inclisiran I don't have